And then back to your point, Mel, earlier, you said, your pain's never going to be a zero. So we tell patients from the onset, like, our goal is to get you to like a 3 or 4, maybe a 5, whatever's manageable, but your pain's not going to be zero until maybe a few weeks after surgery.
Okay. So wait it out. Know that it's going to take about 3 to 4 weeks if he'll get you to zero, basically.
Probably 2 to 3. I don't know. Ashlyn,
I
0?
would say depending on your swelling.
You
If
were a
you are
0 on
doing
day one, I guess.
well with your swelling management, then yes. If you are not doing well with your swelling management, you're like, I'm good to go. I don't need to do all this, then your pain's probably going to return.
Hey guys, it's Mel, your host of the Cutting Edge podcast. This is a show where we talk transformation from every angle: body, mind, and confidence, with a little sparkle and a whole lot of truth. I'm joined by my amazing co-host, Dr. Omar Beidas, and the plastic surgery pro, and Ashlyn Douglas Barnes, our go-to therapist and mindset queen. Now, quick disclaimer, none of us are your doctor or therapist. We are just here sharing real talk, real stories, and real growth. So grab your protein shake, settle in, and let's get into it. This is The Cutting Edge.
Hey, it's Ashlyn. Just one more thing before we begin. I will be sharing some of my own plastic surgery journey, which is personal to me and may not reflect what others go through. And if you're a current client of mine, please talk with me first before listening, because knowing personal details about me could affect your therapy. And your well-being always comes first. Now on to the show.
Welcome back to the Cutting Edge podcast. This is where you're going to get all of your information and resources about getting plastic surgery, what it's like, how much it might afford, what kind of support you're going to need. And of course, we have a surgeon and we have a therapist with us to make sure we know what to do at all times. So I am your host, Mel.
I'm Ashlyn Douglas Barnes, licensed clinical social worker.
Omar Beidas, board certified plastic surgeon.
That's right. So today, guys, we are going to be talking about pain because I am 10 years post-op from bariatrics. I've not gotten my plastics done. I do want it done. I've gone back and forth, but a lot of the back and forth has been about pain. So I'm really happy we're going to be talking about this subject because I I I don't know if I'm going to be a sissy Lala or not. So you tell me, what is the pain even like? Considering, Ashlyn, you've had several rounds of plastics.
I am a terrible, I will preface this that I have abnormal pain tolerance. I have incredibly high pain tolerance. I have a very hard time gauging pain for people because I don't feel it like normal people. So this is going to be a hard one for me to,
How do you know
um,
that?
I cannot take narcotic medication of any kind. I am missing a pathway in my liver that would break it down, and it creates toxicity within the system. So it makes it before we knew that, and I actually had genetic testing to like prove this is what's happening. I had my gallbladder out and did not wake up, and it caused a lot of problems. And what was supposed to be I went home the same day, I was there overnight, and it took a really long time. Also, pain meds and anesthesia is done by weight. Is that correct?
For the most part,
For the
yeah.
most part. And so when I was heavier, when I was like, I think I was close to like 270, 280 for that surgery. So they used a lot of it. And
Mm.
so I think that was also part of it. I deal with it very differently at 120 than I did at 280.
For the
Um,
medical nerds, what's the is there a condition, or you just have?
um, so it was really interesting. So there's Gensight is the test that I got, and I was actually getting tested for antidepressants, I think, because I have a hard time also with antidepressants for the same reason. And so, because that that company does pain meds, mental health meds, and one other thing, I can't remember what it was, maybe high blood pressure, cardiac drugs. So, I was gonna pay for it anyways. So she's like, "Yeah, let's just run the whole thing." And I was like, "I'm so curious, what pain meds can I take?" Because I had had 2 surgeries at that point. I had my knee done when I was, like, 18, I had my tonsils out and my gallbladder out, and I had an absolute horrible time with pain management medication because I don't tolerate any of it, and so I'm like, "Cool, we'll take this test, and I'll find out what I can take."
Yeah.
And my doctor called me, and she was like, "I have some bad news for you." She's like, "There's 3 things, but you can't actually use." So it said that I can take Suboxone, which is not pain
Mm.
medication.
Nope.
I can take naltrexone, which is not pain medication. We will talk about that too because that's important later. Um, I can take, I think like Advil and
Methadone.
Tylenol, they were okay, but all the opiates, all of them, and then what it did is it says like use with caution, and it explains why. There's all different, like if you're a smoker, you need a higher dose, or if you may need to start at a lower dose. And then there's like contraindication, like you should not use, and then there's like a footnote, and in the footnote it explained why. And that was the one where it was like you are missing the pathway, and so increased tox- uh, toxicology.
Toxicity?
Hey friends, this episode is sponsored by findabariatrictherapist.com because bariatric life is full of ups and downs and everything in between, but you don't have to go through it alone. Findabariatrictherapist.com makes it easy to connect with therapists who truly understand your journey, the mindset shifts, the identity changes, and all the real life challenges that come after surgery. Because therapy designed for bariatric patients changes everything. Visit findabariatrictherapist.com and find your support today.
Toxic level, whatever.
Toxicity?
Yeah, so it like builds up in your system, and so the weird thing is if I take it, it makes me sick and I still feel pain. It's very weird.
Huh.
So it doesn't work. So what I figured out, I had a very lovely, so I brought that paper in, and I had surgery at the Mayo Clinic. I can't remember what I was having. And they brought in like every student person, and
Yeah,
then they
I can
all
imagine
looked
that.
at it, right? And they're all looking at it, and they're like, wow. So the guy comes in, he was so kind. And I remember I just being like, because I hate anesthesia. It's like, I don't care what surgery I'm having. I'm like, surgeon, I'm good. Come sign my knee, whatever we're doing. But it's like anesthesia. I'm always like, you're not the one I like. And anesthesiologists don't like not being liked, because most of the time people are like, yay, you're going to give me meds and put me to sleep. So I'm like, I don't like you. And I don't have issues with anesthesia. It's the pain meds. So what that doctor told me, and it has worked really, really well, is that I need short acting pain medication like fentanyl, and then a delayed wake up. So that way the last set of fentanyl is given, and then they delay me waking up. And then by the time I wake up, it's completely out of my system. So even though fentanyl is an opiate, and it can, in large doses, can make, and most of the time I just tell them, don't give me anything. But the problem is that how they've always explained it to me, if I'm giving unconscious signals of pain, they have to treat it while you're under. And so even though I'm saying I don't want anything, it can cause problems if left untreated. So I've had all the last sets of skin removal with that setup where we do fentanyl with the delayed wake up. And I had nasal surgery that way, and that went well.
But what about, sorry to interrupt, what about after surgery? Like after you wake up?
Nothing. Absolutely nothing. I don't take anything. So I get, again, we talked about this last time. This is not for everyone, but I take liquid Valium, which is a benzodiazepine. It is not a pain management medication, but it calms me down enough from the pain. But I don't actually
That's why.
feel pain. That it's weird. The only one that I felt and was like, I finally called and was like, I don't know what we're gonna do, and they gave me what's the nerve medication?
Gabapentin or Lyrica? Okay.
Gabapentin. That actually I did great, and then we knew for the next surgery to use that. So now I just use that automatically, but it takes me a little while to wean off of it. It's interesting. That's an interesting one. I'm here and there on that. But yeah, so I can't. So the worst one was when I had the muscle repair.
Makes
Because
sense.
that was like ice, like zzz, like I can handle that kind of like wah 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 pain that's kind of like radiating. I think radiating is wah wah wah. But the ice pick of, and I wasn't really prepared for the amount of muscle repair we did, so I didn't have maybe all the things I could have had to maybe help me. But yeah, afterwards, it's
And you
liquid.
didn't have Exparel, right? Sorry.
I
I think we
did.
talked
I
about.
did.
Oh, you
I
did?
did have that, and I tolerate that very well. Though the day it wears off, you're kind of like, "Woo! I
Yeah.
wish I had a little more." So yeah, so I could use Exparel, liquid Valium, and the only reason we use liquid is just because it works faster. Muscle relaxers for like spasms, but most of the time I'm just trying to sleep. But so I literally through all the surgeries I don't even feel it because there's no point.
So you're an anomaly.
I am an anomaly.
Yeah. This is very interesting. I have a lot of medical questions.
What me and most people in the world are going to have when they have surgery, it sounds like. So
I think though that most people do find, and I mean, you're what percentage of people do you think are calling afterwards for explain actually maybe we should back up, kind of explain like what Dr. Beidas, like what your normal protocol is, and then what percentage of people are calling who are like, I need to go beyond this protocol.
So I don't know, Mel, did you want to say something?
I
Yeah,
just
like,
wanted to
like
know
you're gonna
what
say.
I was gonna say which surgeries are more painful than the others. That's all I was
Oh,
wondering.
okay. Great question. I do think the tummy tuck or anytime where you're tightening muscles, at least in terms of plastic surgery, is one of the most painful. Um,
Okay.
I think if you're getting a breast augmentation and your surgeon's going under the muscle, that's also painful. I don't do it that way. I do a subfascial, so the muscle stays intact. Um, so my breast augmentation patients are usually fine, like in a day or two, basically. So okay, Ashton, back to your question. So we use something in our practice called ERAS protocol. Um, and ERAS is an international, it stands for Enhanced Recovery After Surgery. It's an international society that was formed. Um, and they put out guidelines and recommendations on how to treat patients and how to manage pain before, during, and after surgery. Um, it's kind of a complicated protocol, but essentially it actually starts with preoperative preoperative treatment. That doesn't actually only include pain. It includes things like warming patients up. So I don't know if you've had surgery, they might have put like a warming blanket on you in the preoperative area.
It
That's
shoots
because once
hot air,
yeah,
and it's
that's
like
because
this
once
purple
yeah, it's called
jackety
a bear
thing.
hugger, Bair, not like a grizzly bear.
Mm,
Um,
it's quite comfortable, actually.
It is. Most people like it, although after a while, I think people start to sweat and then they don't want it anymore. Things like decreasing risk of DVT, which are clots that can form in your legs and go to your lungs. So all these things are in this ERS. But when we talk specifically about pain, we're gonna give a few medications in the pre-op area. So those are Celebrex, and most bariatric surgery patients can tolerate that for a short amount of time, even though it is an NSAID. It's a selective NSAID. Um, we're going to give gabapentin, Tylenol, and I believe there may be a muscle relaxer as well in the pre-op area. And then sometimes people do blocks in the pre-op area. I prefer to do my blocks in the operating room because usually we're doing multiple body parts. So if I'm doing like a total upper body lift, like arms, breasts, back, it's very hard for the anesthesiologist to block all those areas on you awake, and it's multiple, needle sticks and things like that. So I prefer to do it while someone's asleep. We do the back, we numb it. We do the breasts, we numb it. We do the arms, we numb it, and so on and so forth. And we use Exparel, which is really just a numbing agent that's created in a way that it's going to last about 2 to 3 days. So it really gets people through that first kind of 72-ish hours um, of pain. And it's not going to make it zero, but for most patients, I would say they tell us it's less than a six or less.
Oh, good.
Um, yeah, so pretty reasonable. And then we in our practice again, we do those same 4 or 5 medications. So again, Celebrex, gabapentin, a muscle relaxer. Usually we use methocarbamol, Tylenol. I'm missing one. Oh, and then oxy's the last one, right? So some narcotic, we use oxycodone. And Percocet is a mixture of oxy and Tylenol. We prefer to separate them, just so you don't take too much Tylenol at one time. And so we give 6 oxycodones in our practice. I would say 95% of patients don't ever call us for a refill. I think there is there was, if you all remember, like 15, 20 years ago, this opioid crisis that we had, right? So people, I think, are acutely aware of addiction, almost to the point sometimes where I think people are afraid to even take the narcotics. I mean, most of my patients don't take any. And I think that's a testament to, we have a really good team of nurse practitioners and PAs who've kept this ERS protocol going and kind of make sure we're following the latest guidelines. I think Exparel's been a huge game changer in body contouring. And so most patients are okay with the other 4 meds. The gabapentin is really the only one that we tell patients to take around the clock. And the reason is that's that nerve medication. The
Yeah.
reason is that one takes time to build a steady state in your system. So if you take it kind of as needed, it doesn't work. You got to take it till it builds a steady state. Use it. We give it for 2 weeks. So you take it for 2 weeks and then you come off of it. Sometimes people need a taper. Um, the rest are as needed. So all your other medications for pain are as needed. So yeah, I would say very, very few patients call for a refill, and it's kind of funny because I was mentioning this to you guys earlier before we aired. My nurses and our office staff, when someone calls for a refill, it's like panic mode because they're like, well, "We can't give a refill. We've already given 6." And I'm like, "We just did, like we had this a few weeks ago. We had done a lower body lift and a thigh-plasty on a patient at the same time, right?
Oh,
This is like an 11-hour surgery,
wow.
probably the worst combination of things to have together. And she called like a week later, and she wanted a refill. And I said, "Okay, so she's taken 1 oxy a day for like the last 7 days." I was like,
Hmm.
"I think she can get a refill, guys. She's gonna be okay. I don't think she's abusing, right?" So there's this kind of like panic or hysteria when people want a refill, and I have to remind my staff sometimes, like, "Okay, this is a big surgery. You can give this patient a refill."
Yeah.
Yeah, I think that we've gone way to the other side. And I get it. I mean, even my ex-husband, that's what his choice was Oxy. That's what he was addicted to too. So I get the paranoia and the scarcity behind it. Um, but it's also like we have to be rational too. It's like, okay, what, because I know like watching him go through like the medical part of it, like when you're in that much pain, he needed at least 2 to 3 a day for the pain part to go away. So if you're only getting one a day and you're getting it only like for 6 days, like that's like nothing for how it was regularly used. Like I would assumed it was you were like they probably prescribed at least 2 to 3 a day back in the day. So I
Or
mean
at a
that's
time.
obviously
Yeah.
like a huge shift and difference, and realizing that we don't need them that often. Because I know, like I broke my leg 2008. Yeah, 2008. And I remember after surgery, like they give you the pain meds, you do the pain meds, right? I was done with the pain meds. Once the bottle was done, I was done, whatever. But when I go back up just to get a checkup, they're like, "Oh, we need to refill her. Oh, we need to refill." Like
Oh,
that was the deal. It was like I didn't even ask. They were like, "We should refill her. Like she's got to be in pain." And I go, "Hey, hey, hey, I don't need that." And they're like, "Wait, what?" And I go, "Oh, I'm in pain, but like Tylenol's just fine, guys. Like elevation, ice, whatever I need to do. Like I don't need another bottle of that because it was actually like I want to say like 60 pills at a time.
I was gonna say there used to be a time when people would give like 90 pills for like a small like carpal tunnel release, right? I mean,
Yeah. Or
that's
dental
something
stuff.
we can
Dental
do in the
stuff. Yeah.
office. You numb them and we tell them take Tylenol now. We don't even give them any narcotics. But
Yeah,
90 pills, 60 pills, as you just said, that was kind of,
common.
normal almost
Yeah.
20 years ago. Yeah.
Isn't that crazy to see? Like, okay, we actually were way over prescribing and realizing, like, hey, just because they're in pain doesn't mean that we need to get it to a zero. I think that was probably the case too. Is like, I don't think we'll ever get them to a zero unless they go to sleep,
Hmm.
like,
Correct.
and we really shouldn't be using oxys to get people to go to sleep. So, like, that's actually a whole backwards thing, and it's not going to help with that. So,
Correct.
um,
Yeah.
so yeah,
And
I mean, I know for me, was worried about the pain. Not that I've had a broken leg, I've had a Dylan, I've had a kid, but like they've been so far apart. Like Dylan's 19 years old. That break happened in '08, so that's like again, what is that, like 15, 16 years ago? I haven't had anything like major since then. So I'm like, and I don't even count, yes, I had bariatric surgery, but I felt like that was like, surgery. Like how I was supposed to feel. It wasn't anything crazy. Like I was sore. Yes, it sucked to not be able to lay on my stomach for a few, like about a month or so. Yeah. But like it wasn't a huge pain deal. Um, so like
and
I just don't know, but I see people online all the time. They're walking slow, they look like they're robots and like they can't move and like,
Well, some
I'm
of
just
that isn't necessarily pain as much as just like sometimes your posture is impacted by, especially tummy tucks, like where you
yeah,
Mhm.
can't
but
stand
it
up straight all
looks
the way.
painful the way you're walking because I even watched Ashlyn when she came out to fucking
Oh,
Merry Christmas.
but I had just gotten like part of my arm and like under like I had that was my last revision. So yes, no, my arms were a little because we did done work in my armpit. So
Mhm.
yes, yes, I was a little altered in how I could move.
She was definitely robotic, like it was great, but I was
I
just
think I
like,
also went out like 10 days. So I mean I just had
you were wild. I was very impressed with you. I was like, I can't believe she's coming. Like she's gnarly right now, but you know what? You did. We had a great time.
Yeah.
But
No, that
just
one was not
watching
bad.
you made me a little nervous. I was like, oh fuck, I don't
No, I
know.
felt fine. I was kind of tired.
Just kind of tired.
Um,
I was also trying to sleep like in a different way that I normally sleep, and that was definitely impacting that.
So that's going to impact pain too, right? So like obviously like where you get the surgery at, like on your body, to how are you able to sleep is going to like
Yeah, because I
determine.
normally sleep on my side, and in that and for that surgery, I slept on the couch with a pillow, like a triangle pillow, with it all the way up. So triangle pillow. So I was kind of up like this, but my legs were like what is that called? The recliner part was up, and
mm,
then there was a
That had the
triangle, so that way there wasn't as much pulling on the abdominal, but I was also sitting up. So I was fine once I like figured out how to like use all the pillows on the couch with the recliner, but that took a little while. And then because I was at um, in a different space,
and
I didn't have all my stuff, so I was creating that in someone else's space.
it was so funny. It's so funny.
I
Figured it
mean,
out.
I would say for the vast majority of like women, especially, right? That's mostly who gets these procedures. When they compare it to their gastric surgery, or Roux-en-Y, whichever they had, or like a C-section, most say while a tummy tuck is painful, it's less painful than those two surgeries because if you're going inside the abdomen, right, like tummy tuck, or sorry, bariatric surgery, hysterectomy, you're cutting through the muscles of the abdominal wall. With a
Right.
tummy tuck, we're not cutting through the muscles, and the suturing is mostly happening kind of on the outer layer that covers the muscle. So the muscle is here, and you've got this fascia. It's a thick white band, and the sutures are mostly just grabbing this stuff and bringing it together. Um, so I think that's probably why it's not as painful, but I've had a few women tell me that it is in fact more painful than like their C-section or gastric sleeve, for example, but those are few and far between.
Well, and you said basically any woman that's had a baby, or if we've had like, the overweight or our stomachs have gotten so extended that we're going to need muscle repair regardless, right?
I would
So,
say the vast majority, yes.
yeah,
And
yeah,
some men too.
And men
yeah.
who've been overweight, yeah, of course.
Yeah.
Yeah. Absolutely. I mean, the way the muscles are, right? When you're born, they're kind of like curved a little bit, but they're, from your lower ribs to your pubic area, your pubic symphysis. And as you stretch that, if you've had a baby or you've gained some visceral fat by being overweight, you tend to stretch them this way. And then when you lose your weight, it's kind of like the skin. Not everything goes back the way it was, so they still have a little bit of a separation. And so that's what the tummy tuck does, is it's going to bring those muscles back in the middle.
Ooh, so does that mean that like now that I'm going to do my body competition, that like I could lose, like I can get down to where I could see my abs and then you could just like put them next to each other?
Mhm. Correct.
Nice. Yes. Yes. Because I'm sure that's what, like, I'm sure that happens to women, right? Like they go get smaller, they get abs, but it's like not in the normal spots, probably.
Correct.
Uh,
You can see
yeah.
in some women, it almost, some people come in thinking they have a hernia, right? A hernia is an actual, I don't want to say hole, but essentially it is a hole. It's a defect in that fascial layer that surrounds your muscles. Um, but really, it's just diastasis. That's how bad their diastasis is. Everything is kind of just weak in the middle, and they get this central bulge kind of from above the belly button to below the belly button, or sometimes it's just around the belly button. Um, and really, that's just their diastasis.
Okay.
Yeah, I had a lot of muscle repair at the top, kind of like where the T came together under the breast, and then I had some at the bottom. But I had had previous, like I had a hiatal hernia repair. I've had previous both OBGYN and other gastric surgeries. So
Stuff. Oh yeah. So how did it feel like what do the patients say about muscle repair just in general? Does it just no matter what, it's going to be painful?
what I will say, even though it was the most painful part, it's the part that probably made the absolute most difference in
Wait, what
how
did, sorry?
the muscle repair made the most difference for how it actually looked.
Oh,
Because
how it
I had a
looks. Correct.
pandectomy without muscle repair, and that was an error. I should not have done it that way.
Mm.
But I don't think we totally knew. I don't know. Like we should have done what I did the second time, the fleur de lis, capital I. We should have done that the first time and repaired the muscle because that had a much better effect than the initial pandectomy. So even though it was painful, I would have done that. I would have done that from the beginning.
Mm.
I also would have done lipo because I was so afraid lipo was going to be so incredibly awful and painful.
No.
I
For
would
us,
say
at
that.
least for many of my patients, at least, I do think the soreness is in the lipo because that's where the Exparel, we can inject the Exparel in the fascia, so we can use it on the arms and the belly and the breasts. But where you lipo is very difficult to put that because it's such a large area. And we do use like a shorter acting numbing agent. Usually it's going to last like maybe 12 to 18 hours. So within a day, you're going to have soreness in the area. Like when we do like 360 lipo, I tell patients, be ready for some pain, be ready for some swelling. And it's very uncomfortable those first 2 weeks, I would say.
Well, and when we do the 360, that's when like and you'll just automatically do the muscle repair and you'll automatically do the lipo.
With the 360 body lift, yes.
Yeah.
Yeah. Muscle repair. It's basically a tummy tuck, an outer thigh lift, and a buttock lift. And a lot of times we're doing lipo at the same time, 360. And for a lot of weight loss patients, we do a BBL at the same time.
Oh.
Because otherwise you're gonna lose your butt. That's the
Otherwise, there's
reason
no
I did not
volume
want
there.
to get
Correct.
the butt lift, because I had never seen one that looked like their butt was still there.
Yes, most patients need that volume back. So you've got to give it to them somehow.
It's melted.
So then I guess I'm confused. I thought like, okay, then there's a tummy tuck 360, right?
Same as it. So that has many different names. Yes. So
Okay.
some people call it a 360 abdominoplasty, 360 tummy tuck, lower body lift. Some people call it a belt lipectomy, which is kind of an older term. And technically, a belt lipectomy, the scar is a little bit higher, like where your belt is.
Mm,
Really, you want the scar to be more at your like hip bone,
yeah. Yeah.
or like bikini line. What other names does it have? Circumferential body lift, circumferential tummy tuck. They're all the same thing.
So because we talked this before, like I want the 360 like tummy tuck, but are you would do like a butt lift with that?
Yeah, that's what it includes. So that's what it is when it's a 360.
Okay. So then you'll make sure that top part looks like a butt. Is that what I'm understanding?
Correct. So you lift the buttocks because a lot of
Otherwise,
times
it's just gonna lift
that's
it.
just sagged, and then you've got to put volume back in. So sometimes you can use that tissue that you would otherwise discard, and you kind of flip it back down or rotate it down. So you get rid of the skin, but you don't get rid of the fat. Or other times you do fat transfer like a BBL.
Mm-hmm. Yeah, because I would want fat transfer
Yeah.
for sure. I'm trying to think of where you would take it, but I guess you're the doctor. Well, where do you normally take
Don't
it from?
worry,
Everywhere
I
else.
will
The back,
find it.
the thighs, the tummy.
Smart.
Yeah.
Okay. So then with pain, I guess the biggest thing is that like how long does pain typically last? Or is that again just going to be about the person?
I think it does depend somewhat on the person. Again, we talk about red flags. Generally, I think, like I said, we give 6 pills, and this is down from 12. We used to do 12 oxys about 7, 8, maybe 9 months ago. We switched down to 6 because we found out we kind of did a poll, and most patients weren't taking more than 6 anyway. Um, I would say on the bigger cases, like I was mentioning earlier, this patient, like a lower body lift, probably gonna need more than 6. I've probably had a few who didn't take more than that. Um, Sorry, what was your question?
How
I lost
long
my
will
train
the
of
pain
thought.
last? Like how long is like
Oh,
typical?
um, I'd say a week is when it's the worst, and then it starts to get better. And if you've made it a week and you've only taken 6, you're probably going to be okay at that point, or haven't even used your 6. I think also the other thing, we talked about tummy tucks and muscle tightening a few minutes ago, but I think the other thing that's really important is realizing that not all pain is going to be treated with oxy, right? So nerve pain, that's why we tell patients you take the gabapentin whether you feel like you need it or not, because that's just the way it works, right?
It
Uh,
builds.
so that takes care of nerve pain. Now you've got muscle pain, which are like cramps or Charlie horses. That is mostly the pain you're going to have from the muscle tightening or the tummy tuck, their diastasis repair. So for
Okay.
that, generally we tell patients if you're getting cramping or like a muscle ache, you want to take your muscle relaxer, not your oxy. So a lot of it's on education. And then back to your point, Mel, earlier, you said, your pain's never going to be a 0. So we tell patients from the onset, like, our goal is to get you to like a 3 or 4, maybe a 5, whatever's manageable, but your pain's not going to be 0 until maybe a few weeks after surgery.
Okay, so wait it out. Know that it's going to take about 3 to 4 weeks to feel get you to 0, basically.
Probably 2 to 3. I don't know. Ashlyn,
I
0?
would say depending on your swelling.
You
If
were a
you are
0 on
doing
day 1, I guess.
well with your swelling management, then yes. If you are not doing well with your swelling management, you're like, I'm good to go. I don't need to do all this, then your pain's probably going to return. So I always found the better I was with swelling management, the better I was with pain. Um,
Okay. Well, what well then let's ask it. What helps with swelling? So we can make sure we help ourselves.
And
like,
that's a great point because I think we mentioned earlier on an episode, swelling
yeah.
it can cause pain or it can cause discomfort. Things that can help, we recommend a high protein diet, and then we recommend compression garments, and MLD, which is manual lymphatic drainage.
Question for you. I know that some of my surgeons were like, no, and some were like, maybe it
With what?
wasn't
Sorry.
with ice. So when you
Mm,
have like a knee operation or something, they have the ice chest that shoots cold water. So what I got for my
what happened to a frozen bag of peas?
no, this thing is amazing. So you put ice in there and it shoots the water, it circulates it. So it stays really, really cold. And so you can
A
get
swamp cooler is what
hmm?
it's called a swamp cooler is what us
Swamp
yeah.
cooler?
I've
Swamp.
never heard it called, but I had
Swamp.
one.
Okay.
Yeah, it's for those that can't afford a real AC. This is what we would use.
Oh.
Oh, okay. See, we're from
Huh.
the land of you can't not have an AC, you die. So I don't know
Yes, you
anyone who
would.
doesn't have one of those.
Here in
But
Oregon, there's only a couple months you might need an AC, and we call those swamp coolers.
Interesting.
interesting.
Okay.
So I had one
You
for a knee. And so when I had my stomach surgery, I pulled that bad boy out and I was using it. My surgeon was like, I don't know how I feel about ice, but it was really helpful. So I was kind of surprised that that was kind of a
wanna
no go.
I wanna go back to the swamp cooler. Are there swamps in Oregon?
No, no.
Okay, I didn't think so. That's why I was like, why did that term? I was like, I
It
could
was
see that
hot.
in Florida. We have lots of swamps
It's
here.
hot and sweaty.
It's hot.
I
It's
see. Okay.
swampy. I mean, I can't take that term. Like I mean, my family from Oregon, from California and Arizona call it that. So that's where it came from. So I don't even know if that's an Oregon thing because I was actually born in California. So we came
No
up here
swamps there either.
when I was 6. So yes, they do not have swamps in California either. No, no, just where
Um,
you guys are.
okay, Ashlyn, sorry. To your
That's
question.
okay. Why, yeah. Why is ice sometimes a no go?
So
Yeah.
I would probably avoid, I mean, you have to know your patient, I guess, right? I would say for the vast majority of patients, we don't recommend it because you can cause frostbite essentially. If you leave that on for too long, right, and you have like after a tummy tuck or any operation, generally that skin is numb. And so you put an ice pack on, you forget that it's there, it's on for an hour, and now you've just kind of frozen your tissue and essentially killed it. I mean, that's what like cryolipolysis is, right? Like
Right.
things like cool sculpting. It's freezing fat, and so that's okay when you haven't had a surgery. But when you've had a surgery and you've already kind of, I don't want to say, I want to pick my word carefully here. You've decreased the blood supply to that area, whether by lipo or by cutting out like a tummy tuck or a piece of skin, and then you add ice. You're kind of adding insult to injury.
Oh,
Um,
okay.
so my guess is your doctor was telling you that just because he was afraid, and I would be too, that you do that and then forget that it's there, and then you go in and you're like, I have this black area on my stomach
Well,
because you
and I
killed
had
the
all
skin.
the like compression, like I had many layers between me and and it wasn't direct ice. It's a pad that's running ice water through it. I
We've
don't.
seen it all. I've seen women put like hot pads after surgery, and then killed some tissue. I've seen women, um, there was like one woman who like like she tried to iron her blouse with her after like her breast reconstruction. Like this was a few months later, and then like her breast was numb because she had a mastectomy, burned her breast tissue, and then suddenly she has an exposed. I mean, you do this long enough, you hear all kinds of crazy stories. So
So she was
um
ironing her own shirt on her.
on, yes, on her, and her breast is numb. and now she basically like
Are you
ironed her
about to
breast.
tell us that she had an exposed implant?
Yeah, she had an
Oh,
exposed implant
no!
eventually. Yeah, I mean not that day, but
But
as
she
tissue died
eventually
and
did.
whatnot, she eventually did.
Ooh! Ah, now
No.
that would fucking hurt, and that would need some
Yeah.
pain meds for sure.
Especially
For
knowing you did it to yourself. Oh
well,
my
I'd be so mad
god.
at myself. Who irons with your clothes on? What is she
I have a
thinking?
feeling she
By the
probably
way,
got
I'm
away
sure
with
she's
it.
not the only one.
No, no, no. Because think about it. People, you're probably used to it. You pull it out.
Maybe it was a steamer. I don't know. Yeah, I don't.
I may or may not have done that before. But you just pull it away, but you just don't have a dryer.
You're
In a
so
hotel.
funny. You're so nope, never done.
Yeah, so
I
I
know.
would expect, or I would suspect that's why and we generally tell patients also like don't ice. And if they start pushing and they really want to, I'll tell them, 15 minutes at a time. That's
Yeah.
15 minutes an hour, no more than 15 minutes and set a timer. But we generally tell patients to really avoid, especially in the first like 10 days, because again, that's where your tissues have taken the most insult from surgery and your body's still trying to regenerate blood vessels and grow blood vessels to make sure that area heals.
Yeah, so if you put cold compression on it, it can slow it down, right?
Correct.
Yeah.
Mhm.
Yeah.
Or freeze it. I mean,
Freeze
essentially,
it
just kind of
basically,
like,
yeah.
yeah, yeah,
So then it's like it's freezing and then you're warming it up afterwards. And then like so it's not helping.
Yeah. So, moral of the story, listen to your surgeons.
yeah.
They may
Yes.
know something about that.
Well, and I was thinking the 15-minute thing is like known for always. Like that's what you're supposed to do is 15 minutes of cold, 15 minutes of hot. Don't do that too much. Alternate, blah, blah, blah. So it's
Yeah.
like same sense with
Well,
your
especially if you're on pain meds too and you accidentally fell asleep. I could
It would,
I could
yeah,
also
right. You
see
fall
that
one.
too.
asleep. I mean,
Yeah.
exactly. And then, Ashton, you made a good point. Like you had multiple layers of clothing, so it's probably okay in that situation. But like, not everyone's going to think to, someone might just put it, on their naked skin, and so that's very different than having like 3 layers of compression, for example.
Oh yeah. Which
Yeah.
I know I've watched people do it just when they're like sore leg, or they have like twisted their ankle. And I've watched them just put it straight on and I'm like, that's just gonna
Ugh.
that's not gonna feel nice
No.
here in a minute. And then within a minute they're like, someone help me get a towel. Like yeah, you can't put anything direct like that. Like you are crazy. I have this cooling, I got it for Christmas from my brother and it's like a cooling mask that you can put on. You put it in the freezer and then you pull it out, you wait a minute or two, and then you can put it on. It's supposed to help with headaches and calm everything down. But one time, just for shits and giggles, we all were like playing around with it. We're like, all right, how long could you last wearing
Oh,
it?
geez.
Oh no.
Guys,
Frostbite.
it did not help. It did not help a headache. It initiated that headache. And it was insane. Like I lasted only like I think it was like 32 seconds. And I was like, oh my God, like this is insane. Like this hurts, it's painful. And then my niece did it and she lasted a whole minute. And I was like, I don't even know how you're going this far. Like this is crazy. I finally told him, like, hey, if it hurts, you can take it off. I think it hurt for a while. She just didn't want to take it off. I was like, yeah, don't do anything direct, guys. It'll cause like my head felt really weird.
You like constricted a bunch of blood vessels. It's not a good idea.
No, by any means. I felt so awkward. Like for a good like half hour, I was like, this I feel real weird. I'm never gonna use that for that purpose ever again.
I have a
We're just
heated
having
one.
some
One you
fun.
put in the microwave for I get back of the head headaches. It's
Oh,
very
those are
effective.
nice.
It's very strange. I'm always like,
Just needed it.
hardcore meds can't knock this out, but my microwaved rice pad
Can.
can.
Because I mean, that's the one thing about like our bodies. It's pretty fascinating. Like, like we didn't have all this man-made shit before. So it's like our body had to learn to adapt and adjust pretty much to everything and anything
Well,
around
and
us.
I think that's part of why I have high pain tolerance. Is I went through a really painful surgery as a kid and
Mm,
couldn't take anything and tried and just had to kind of deal with it.
deal with
And
it.
yeah,
Yeah.
like a
Like morphine
partial.
doesn't work on me. We found out that the hard way. That was when the broken leg, that really sucked.
I think I
Because
remember you saying that.
yeah, the morphine was too like didn't work. The pills didn't work. I could feel everything. They just all said that I sounded funny. I was just like, I can feel everything. And then I would just puke. They maxed me out on everything. So they had to wait for it to come down. And then
What
I'm
did they
just
end up? But they ended up finding something for you, didn't they? Fentanyl.
Yeah, they no,
No,
they
Dilaudid?
basically it was fentanyl. What they did was is that they waited for everything to calm down and then they just gave me oxy by itself and then it was fine.
Oxy.
Yeah. Yeah, it's just that they compounded like they gave me oxy and morphine all at once. And so I was like a lunatic just like but nothing I could feel everything. So they're like, "Oh, now we know." That they put it on my chart now, like morphine does not work.
And if you
That's
have problems at Genocide, it's Gene Site, and I think it's Genocide. There is some like genetic testing that you can get done if you're someone who struggles with that to see if there is one that works better than others, or at least help you figure out if there's a strategy, which is ultimately what we figured out.
I'm kind of surprised that that's not automatically done with like
Oh,
once you've gone through
I'm sure it's expensive.
everything's expensive.
I mean, I self-paid, but through like a program where it was like based on your income. And at the time, I was pretty broke, so I was happy to pay the $200 because I think it was a multi-thousand-dollar test.
For
But
sure.
I think they also at that time wanted more people to use it and show it to doctors, and then doctors be interested in then being able to use it within their practice.
Yeah,
So I think they also saw it as like a marketing thing. So for me to be, which the
it is.
I remember showing the doctors like writing like, "What is this? How did you get this? Like, what is it?" Because it actually had all the pathways on it that are the problematic pathways. And
Oh,
so they
wow.
could also then, knowing what they knew, be able to make medical decisions, knowing that the pathway that this works on doesn't work. So
That's awesome.
What
it was
about things like tramadol? It's like an opioid with a different receptor. No?
correct. Nope. It is
Hmm.
it's in the second one where
Hmm.
it can be given in very low doses, but or dosing regular still creates that toxicity issue because
Does
my
tramadol work
liver
on
can't clear.
because like every person I fucking know that's used tramadol doesn't work. Even my dog. I've given her 2 tramadol because the first one didn't do shit and the second one still didn't do anything.
I think for the people that pathway is the one affected, it's kind of like why Ozempic works for some people and trizepatide works for other people because
Okay.
trizepatide is an additional pathway that is not included in the. I mean,
I mean,
I'm sure it's
tramadol is it's a weak opioid, and it's also something we can call in over the phone versus like oxy. Percocet is oxy,
you
but
have
like
to have
codeine,
written.
morphone, Dilaudid, all those other ones we cannot call in anymore. Those are controlled substances. So a lot of times, if someone comes in and they finish their first set of oxy, depending on the procedure they had. So again, I mean, we've seen hundreds, if not thousands, of patients, right? So if someone has a tummy tuck and is asking for another round of narcotics, okay, maybe we'll give you 6 more. But if they're coming in like 2 weeks later and they're asking for narcotics, we're like, okay, we understand you're in pain. Obviously, again, we have to gauge that. But usually we might say like, okay, we can't give you oxy, we can give you tramadol. So that's kind of like the next step down as we're trying to like de-escalate them from the full opioids. Um,
That makes
and
sense.
we
Oh
had
yeah,
a
we didn't
patient.
talk about this. What do you do with patients that have like they're recovering addicts? Like
yes. And
that's
it's interesting. I just looked up the actual genocyte test that I had because I was curious.
I'm very curious.
And it's interesting because the fentanyl is actually it says that genotype may impact drug mechanism of action and result in reduced efficacy. And so that was what I got for almost all of the oxys, morphine, hydrocodone, hydromorphine. And then the ones that had the most significant one is, let's
and
see,
these are the ones that don't work, right?
6. So
Yeah.
tramadol was significant interaction, methadone, significant interaction, codeine, significant, and demerol. Um, But it was just hilarious because like my options of the ones that I can use are ones that we do not use for it's like Suboxone derivatives. We don't use that for pain management. And then for non-opiates, that is Genosite also had that. Like I'm all good for like Soma. Um, so all the Advil, but then for Celebrex, Motrin, which I don't know why that's separated from. Oh, naproxen's okay, but actually ibuprofen is used with caution
Hmm.
because the level of action compound may be too high, lower dose may be required. So I get a better, you have to lower the dose of some of these
So interesting.
Celebrex, Advil,
For it to work better.
Flexeril. Oh my gosh. I got to be so careful with Flexeril because I will sleep for 20 hours if I take like a normal person dose. I did that one time. Oh my god, my husband was like wait, he's like,
Are
you've
you
been
alive?
sleeping for 20 hours. Like, are you okay? And Flexeril stays in my system forever. I have to be so careful with driving because
Hmm,
like the next day I will feel it. It's terrible. And
interesting.
then
This
it
What'd they
like
give you? Like a methocarbamol? It's Robaxin.
the interesting thing is though, it's like trying to get money out of uh the treasury. Soma. I do the best with
Oh,
Soma, but
Soma.
they will
Really?
not give you Soma anymore.
Yeah, Soma is
It's
tough. I
so
mean, Soma's
hard to get.
I'm pretty sure Soma's controlled now.
Oh yes, no, it is definitely controlled because the lady at
Yeah.
Walgreens like gave me such a hard time about it, and I'm like, it's the only one I can take and stay awake.
W- One of my
Oh.
colleagues used to give Soma to his patients because he's like, give it to them and they won't call you for like 3 days.
And they won't. They won't. Yeah, it's really interesting. Yeah, the genocide thing is super interesting if you're
Fascinating.
someone who struggles with antidepressants, mental health meds, even ADHD medication, because it can let you know like you need a lower dose. So like with ADHD medication, I need much lower doses than the average population because it breaks down slower, which makes it last longer. So I need
Hmm.
lower doses. So it's very helpful. It also validated because a lot of doctors were like, that's not possible. And I kept being like, I didn't wake up after the surgery and it was very bad. And they were like, I don't think that's possible. And I was like, now I know why.
Right. Yeah. I mean, I think a lot of people would question that. I would question it. But I mean, if you had a piece of paper showing me that you know,
But
had
the
proof, I'd be
greatest
like,
thing, especially because it's all the same, when that happened, that was in Advent. Is good old Dr. Cryer. Fascinating, like absolute jerk. And I will tell that to his
oh,
face, but absolutely wonderful therapist. What I'll just call him a therapist. He's definitely not
surgeon.
great surgeon. You ever need your gallbladder removed, Dr. Cryer will take it out like a champ, but bedside manner, terrible.
oh,
It's
so
like
he's
Mm,
like
great. You know
surgeon.
that like better you get, more asshole you are? He's
mm,
like way up there.
Way
Anyways,
up there.
love you, Dr. Cryer, but I tell you that to your face. Um, Anyways, so that was the surgery where I didn't wake up and I had to be admitted. And it was really helpful that almost all of our hospital system is now connected. So when I had the other surgery, I was like, please open up what happened at Advent Health in Altamont. And they read it and they were like, oh,
Yeah.
yeah, you didn't wake up. And I was like, yes, you had to be admitted. That sounds terrible.
oh, wow.
That also was a terrible anesthesiologist because he did not believe me. And I remember telling him I can't have opiates. Please don't give me opiates. And I knew the second that I like could tell that I was awake, but I couldn't tell anyone I was awake because that was also part of what happened there. I knew immediately he had given me when I had asked him not to.
Hmm.
You can feel it.
Well, and I couldn't wake up, but I was awake. So I could hear everybody around me, but I could, which is not common. Do not worry. I know that's a lot of people's like biggest fears. Because there was a part of the system that was waking up, but part of the system that was not waking up.
Right.
Um, ugh. So I remember finally standing up and feeling like the room, it was like 10,000 feet tall.
Oh, I
Hmm.
bet.
Anyways, I will get back to the question that you asked me. Red flags. So from the men, I'm going to give you the red flags from the mental health side, and then there are
Okay.
probably
Sure.
different red flags from the physical health side. If you're someone that takes pain medication and it feels like it cures your social anxiety, your ADHD, you feel like Superman, that may be an indication that your brain is more susceptible to opiates, pain addiction, medication addiction. It doesn't mean necessarily you shouldn't take it and that you should just live with pain of surgeries. It means that you should be very aware because you have a susceptible brain. Some people will take pain medication and it makes them feel amazing, not just like take away their pain, but feel like they
Euphoria.
euphoria, they don't have a care in the world. That is a very different reaction than the average person who takes pain medication and it makes their pain go away or lessen. And so those are the people that I'm like, hey, like, and I always warn people when they're going in, even my bariatric clients, when we talk about pain management, if you notice that, that's an indication that your brain is susceptible. There are certain people that are more susceptible to opiates addiction because that pathway is lit up a lot more and it impacts more of the brain. And there's a much more scientific way of explaining this. But the easiest way that I explain it is if you notice, particularly I have clients to be like, when I take opiates, it makes me feel like I could do a lot of work. My ADHD goes away. I feel like Superman. I get a lot of things done. I can socialize, and I want to do all those things when I don't normally. It 100% makes sense to me how that could become addicting.
Yeah.
Something takes away the thing that makes my life very challenging. It's very challenging that I can't organize myself or my ADHD can't seem to be managed. But when I take this medication, it all goes away and everything is great because it's a train that can run off the track. So it may seem like, well, I managed it for a while and I got a lot of work done, but now I can't get the pills. And so now I have to get them by other means. And now I'm introducing other, problems into my life that were not there previously. If you're someone that takes pain medication, you also may notice sometimes there's a problem with pain medication addiction where when you come off of it, you will feel pain and that can reinforce the addiction. And so sometimes people will be like, well, but I have pain. And we're like, okay, that actually is more, again, there's more scientific way of explaining this, but like the receptor was shielded by the pain medication. It wasn't that you didn't have pain, it was that you didn't feel it. It was shielded. And so
Banding.
when we take the shield off, sometimes you are feeling now the connection. It isn't actually that there's pain there. Now, this is different. Obviously, if you had surgery, that is there. But sometimes what happens is people get in a cycle. And oftentimes, especially pain med addiction, it is kind of out of nowhere and it's not sought out. You had dental surgery. I had a lot of people that ended up addicted that dental surgery, migraines, catastrophic injury, and then they figured out, well, I had this dental thing, but then I started taking it and I noticed like, whoa, my life is so much better when I'm on opiates. And I'm like, okay, let's
Hmm.
talk about that.
Talk about that.
And it's really hard because if you magically or you found this like magic pill that like took all this stuff away, and I'm saying like, I think we should probably think twice before continuing to take it for that reason. It can be really challenging because you're like, well, I finally found the thing that like fixed all the things. And so again, that's more information to us. So if you have a history of substance abuse, again, doesn't mean that you shouldn't take pain medication. It means that we have to do it under like supervision. And so we need you to be very upfront with your surgeon about it and how we're going to manage it, and have support people involved. So a lot of times when I have clients, particularly bariatrics, they'll tell me, I have a history because I'm doing a site clearance. I have a history of substance abuse. And so we'll talk about like, okay, so what's the plan with your pain meds? And they're like, well, I'm just not going to take any. I'm like, okay, well, what's the backup plan for that? Like if things get too bad, is your plan to go to the hospital? Is your plan to have the medication and someone else have it in the event you need it or don't need it? What is our disposal plan? Therapists have to be very careful, though. There's recently a case brought on by the Florida board where a therapist almost lost their license because they were trying to manage pain medication for a client after surgery, and that
Hmm.
is not our place. So, and unfortunately for this therapist, I think their head was in the right place because they're a
Yeah.
substance abuse counselor. So they were like, okay, you can take one, or okay, you can take another. Like, we should definitely not be managing people's pain medication. Instead, we should be working on like, what's the plan and how
What's your
can I help
plan?
you? Yep, how can I help you? And sometimes the plan is, even though doctors are not crazy about this plan, if the pain gets too much, I'm going to go to the hospital where it's monitored.
Yep.
I'm going to have a single dose. I usually recommend like there's a support person involved, and that person may be the holder of the medication, and then we have a really clear disposal plan. And at a certain point, we decide what the disposal. And again, the therapist is not making these we're talking about it with you so that you can talk to your doctor to say at what point would I no longer need, like, is it likely I won't need it, and then we can dispose of it properly. Dr. Beidas, I'm curious how you handle this with clients that have a history of substance abuse. Like, how do you handle pain medication and those
Yeah,
coverages?
that's a great question. I think everyone handles this differently, but I will say that people actively using pain medication for whatever reason are immediately we tell them, your pain is going to be much more difficult to control.
Yeah.
Um, because their pain threshold, like what might be a 6 for me, it might be a 10 for them. And also they're already taking, let's say, whether it's, the equivalent of like 10 oxy a day. So the 6 pills that we give them, that's like, that's 3 days for them on a typical, like they're taking that every day regardless of their pain level. So now they've had surgery, they're going to eat through those pills in probably a day and a half, if not less. So our protocol, and I mean, a lot of this also comes from Florida law. If you have someone prescribing you pain medication or controlled substances, we don't give any controlled substances. We tell them, here, we give them a piece of paper. We say, here's your surgery plan. Here's your date. Make sure they're aware. We are not managing your pain. We'll give you all the other medications, the muscle relaxer, the nerve, anything that's not controlled. But we're not going to prescribe a controlled substance in addition to someone else giving you a controlled substance.
Yeah.
That usually waves red flags even at the pharmacy. Like, oh,
Yeah, because we have
you get a
E-force.
you get a benzo from, Dr. A, and Dr. B now prescribed you an oxy. We're going to get a lot of calls from the pharmacist saying like, did you know this patient, yada, yada. So we don't want to be involved. We don't want too many cooks in the kitchen in those patients. So we tell them immediately, we're not giving you any controlled substances. Make sure you're coordinating with your pain management doctor, PCP, whoever is prescribing that medication. For patients who have a history of substance abuse, um, I mean, we treat them just like any other patient. We give them the 6 pills. We do tell them, you may have a lower pain threshold and, lower pain tolerance than most patients. You may go through this faster. You might want to talk to your therapist, counselor. Kind of like you said, Ashton, make sure you have a plan. I don't know that we have too many of those patients. And those patients, and not only though, sometimes we have people without any history. There are some that come in and they say, don't even send the narcotic to my pharmacy. Like, don't even send it. I don't want to have the option to pick it up. And I'm of the opinion that that's not necessarily the best plan, because then what happens is they're calling someone at 2 in the morning, or they're going to the hospital in the ER to get some pain medication. So I always tell them, let me send it, because it's easier for us, for the office to send it to your pharmacy. And then you can choose not to pick it up. But then if 2 in the morning, hopefully you have a 24-hour pharmacy, but if at 2 in the morning you're like, you know what, that was a mistake, I messed up, I need something, then you can just go pick it up, and you're not calling, trying to run to the pharmacy in the middle of the night. Your pharmacy's, you just run into so many logistical issues. Maybe they're out. There was a time where oxy was in shortage in some pharmacies. So, that's not the time you want to be
Right.
troubleshooting that.
The
So
worst.
And sometimes
yeah.
too, we'll talk about, like, I know locally for us, the 24-hour Walgreens by Winter Park Hospital. Like, we also think about, where is it going to get called in? That
Mhm.
pharmacy is more likely to be open, to have it. It is right next to a major hospital. It's just the one I know locally to me. So, like, for them, I'm like, is there a local 24-hour one that's close to a hospital system that probably sees a lot of these kind of prescriptions and have it most likely in stock, or probably going to be more willing because it's 8 pills, it's not 90. But in Florida specifically, we have pretty strict. We have
Mhm.
E-Force, which is a management system for pharmacies where all controlled substances are tracked. So I've had clients run into issues where they are on a ADHD controlled substance. They get a benzo from their mental health provider, and now they're getting a pain management prescription from their plastic surgeon, and then E-Force flags it.
Mhm.
And so again, we want to like manage all of that too beforehand. So you're not trying to figure this out. They're saying, hey, you're flagged in E-Force and I'm not going to be able to give you your pain meds. Um,
Ooh.
I have
you're
a
going to have
story
to,
about E-Force.
That's gotta
This was as a resident. We had this patient who had broken his jaw. So we fixed his jaw. Um, and a lot of times in jaw fractures, especially if the patient's not very reliable, you will wire their mouth shut. So we wire him shut, goes home, comes back to the clinic, asks for, and we do liquid oxy, right? Because their jaw is wired shut. They can't take pills. Asks for a refill. And so I go to check the E-Force. A-Force is in many states. I think it's in pretty much every state now, if I'm not
oh,
mistaken. A lot of you can also see neighboring states. Like I can see Georgia and I think Alabama and even like some of the Carolinas in Florida.
can you explain
Um,
what for those that are listening?
yeah, it was the thing Alshan was just talking about, which tracks controlled substances. So I can go in, I can look up a patient by name, date of birth, address, phone number, and then it will show me any prescription that they filled.
Okay.
Not
In
any controlled substance that they
Right.
filled in any of those states that I mentioned.
Okay.
So he asks for a refill of his oxycodone, and again, we're legally obligated by law to check E-force before writing a prescription, and the pharmacists also check it. So there's kind of like a check counter or
Yep.
balance counterbalance, whatever you want to call it.
The
So
verification. Yeah.
yeah, two-step verification.
And his
So
lit up like a Christmas tree.
So yeah, I see like 2 or 3 and I go back and I was like, I went back to the room and I said, "Well, this database is telling me you just filled 180 tablets
I
of
wonder if he
oxy."
broke his jaw on purpose to get. That's a cycle that
I
some
hope
people
not,
get
but
into where when they can't get medication, they
They'll
have
break.
injuries that so they have their friend punch them because they know that they're gonna get, and it
also listen to the rest of the story. It's like it's bad on many counts. So he's like, "Well, that's not true. That wasn't me." Yada yada. I was like, "Okay, maybe there was a mistake." I was like, "Give him the benefit of the doubt." I walk back to my office. I call the CVS where it was filled. Try to reach the pharmacist. I couldn't get a hold of him. I left him a message. I go back and tell the patient, "Look, I can't verify this now, so come back in a week. And if you're still having pain, we can do a refill if it's really not you." Never see the patient again ever. Like he just doesn't show up. I'm not sure how he got his screws out, how he got the hardware out of his mouth. And I eventually did hear from the pharmacist. It looks like basically some doctor. I mean, we don't use paper prescriptions anymore. This is like we're talking like 10, 15 years ago. Some doctor some patient must have stolen a script pad out of their office. A bunch of them are already signed. Big mistake. Um, and the crazy thing is when the pharmacist looked at that specific prescription, so when you write out a prescription, especially for controlled substances, you have to write, it's kind of like a check. You write the number using digits and then you spell it out using letters.
do they
And
not
whoever,
spell it correctly?
no, well, yeah, so they wrote, I think they had written 180 in numbers, but then spelled out 120. And so immediately the pharmacist shouldn't have filled that.
No.
Yeah.
Yeah,
So
They
it was kind
it's
of a crazy story.
interesting. I worked in substance abuse the very beginning of my career, and it was kind of at the height of the pill mills. And what they would do is they would get a van, and everyone would get in the van, and they would drive all around Florida each day. And every day they get a script from a different pain, and it was everyone was kind of in on it. So it's not like these were legitimate pain prescriptions. And then the one guy would collect all of them at night. Then they had a pharmacy that was in on it, and then that pharmacy
Oh,
would. So they
geez.
were getting paid. And I remember I had a very lovely looking female client, and she would always get the most, and she would get the most money. And so she was actually using them. She was getting money for the scripts, and that was funding a different addiction that she had. Um, because that was one that she could legitimately get the prescriptions for to feed an illegitimate, or not it's the wrong way to word. She had an addiction to something, another medication or drug that's not a medication, but that's how she was funding it.
I
oh
I
It's amazing.
once just walking in the hospital found a prescription pad for Norco, no patient it filled out. It had everything but a patient, like but patient info. So signed by the physician. Norco, I think I took a picture of it. I was like, this is crazy. But this was probably like many physicians back in the
Yeah,
day,
and I think
especially in pain clinics.
in mental health, I've definitely seen where the ARNP would get some pre-filled out for benzodiazepines or ADHD medication because the doctor wasn't there that day, and so the way that they ran it is it was there, and then they would fill out the patient part. And I always worried like if that got stolen, like it's just a
Yeah.
bunch of
Signature, signed scripts. I mean, you
yeah.
could do with it whatever you want.
And they were for legitimate prescriptions. It was just a way that the ARNP could fulfill certain prescriptions because in mental health, the doctor has to sign off on benzos and
well,
ADHD
it's just so
medication.
crazy that they would just have them just like
I think it's
laying out.
Laying
To
around.
be honest, I think that's
yeah, and I know for us they weren't necessarily around, but yeah, I mean it like best of intentions, but in the
But
wrong hands.
but it takes one person in that
Yeah.
office, right? Like probably everyone in the office knows, hey, Dr. So and so keeps a bunch of signed
Mhm.
scripts in his top right drawer, even though it's locked. And it takes one person to go and like, hey, I'll pay you X amount for a script pad. And I think that's what happened with this patient is either he stole it or paid someone for that prescription script that someone
yeah.
else had stolen out of this
Yeah.
pain
And
doctor's
that's
office. Because
why if you own a clinic, pay your people money or
Yeah.
they will find way. I always I worked at this one clinic that paid really poorly, and I was always like, this is gonna turn into a much bigger problem when they find out how profitable either selling client information for
Mhm.
tax, making those stupid. It's like, pay those people well, because trying to cheap out on those people will cause you so much more problems down the road. So
And I'm gonna
It's
tell a second story because you mentioned earlier going to the hospital for your pain plan. So this
relevant.
was probably even a crazier story than the first one. So we had a patient who had had bariatric surgery. I think she had had a duodenal switch, if I'm not mistaken. Lost a ton of weight. Great story. Um, we did
Lay down.
we did a bunch of stuff, but the most important part of the story is we did not do her muscle repair. We did just a straight paniculectomy, skin removal on the abdomen. I think it was like a fleur-de-lis paniculectomy, essentially. Wakes up from surgery, has terrible pain, needs to be admitted. So first of all, already that's a red flag. Those patients, again, most of our patients almost always go home, even from a tummy tuck, right? So now this lady who hasn't had any muscle surgery or muscle repair needs to spend the night. Next day, I'm talking to my PA, and my PA tells me she's needing like around the clock IV pain medication. We're like, this is just so, and I'm like, okay. So we keep her another day. Day 2 now in the hospital. I guess day 3 after 2 nights.
and this is solely pain management.
Pain management. Yeah. I mean, these people usually go home the same day. Um, the next nurse who had her, nurses work in shifts, so I think the night nurse was the same nurse both nights. The day nurse changed, and so on the third day, the nurse reaches out to my PA, and so we finally kind of hear the story. The patient's setting an alarm every 6 hours or 4 hours. I can't remember how far we'd space her pain medication. And as soon as the alarm was going off, she's hitting her call button and saying, "I want the IV medication." And I was like, okay, well, first of all, why do we still have this patient on IV pain medication? You shouldn't have even given her IV pain medication from the beginning. So basically, as soon as we cut the IV pain medication off, we weaned down her narcotics. She went home that day, right? She was like, I'm not. And the flag
Once you
didn't really
knew.
go off. Yeah, but the flag, I mean, we suspected it might be an issue. I think she had asked the office afterwards for more pain meds, and we declined. Um,
Lay down.
but then the real tragedy was about 6 months to a year later, I'm walking in the physician's lounge, and we see the OR board, and I see her name on the board, and the procedure she was having done was organ harvesting. So she had, and I went up to see the family and talk to them, and essentially I found out all the backstory then that she was a substance abuser, and she had kind of relapsed, had done a bunch of drugs, and essentially caused
Yeah.
herself to go into organ failure, which is very sad. Very sweet
Yeah.
patient.
And it's
Very sad.
hard too, because particularly for duodenal switch, but all bariatric surgery, your risk of substance abuse, particularly relapse and alcohol, go up.
Yeah.
And so again, it's like having those honest conversations about how we're going to manage this and how are we going to. I mean, that's really hard. And the hard part about pain is I want to make sure I get it right. It's subjective. Yeah, right.
Subjective, yeah, very
Yeah.
subjective.
So what's painful to me, obviously I'm a great example of things that are not painful to me, but the problem is too, it's like I hurt myself sometimes and don't know it. And so it's also not good to not have pain reaction. It's like that's telling you that you're injuring yourself and you should stop whatever you're doing. So I can't power lift anymore. Because I
You mean
tore my.
accidentally injure yourself, right? Or hurt
Correct.
yourself?
So
Okay.
I have torn all
Clarify.
sorts of things and not realized it, because I can't feel that. So I'm a amazing power lifter. When my husband's favorite fun fact about me was there's a point where I could bench press 250 pounds because I can't feel that.
Crazy.
Yeah.
Now I was also over 250 pounds, so I was only benching my own weight, which is not as crazy as a
Hey,
fun fact.
What can you bench now?
don't you do that.
I don't know.
What?
You did
I have no
great.
idea. I also have
Doesn't matter.
PCOS. I had PCOS, and my test. I'm sure my testosterone is through the roof.
I mean,
Naturally on
I
steroids.
don't bench press. I do try to go to the gym, but I don't know what I bench press. But I doubt I could bench press my own weight. So I wouldn't downplay that you can bench press
That's what I'm
250
I
pounds,
saying.
even if
can't
you
do it
weigh 50.
anymore. But that my husband would be like, we'd meet new people. And he's like, "Do you want a fun fact about my girlfriend at the time?" And I was like, "Please don't tell them." And he was like, "She can bench press 250 pounds." That was so amazing to him.
Should
But
give it a
what I
whirl.
found
Not
out,
250. Try, something like start at 100 or something.
well,
See.
the funny thing is I don't power lift at all anymore because I destroyed my shoulder. I've destroyed my knee. I've destroyed because I can't feel it. So you're really good at powerlifting when you can't feel pain because you'll
Yeah.
push through things you shouldn't.
Hmm.
And so I have particularly my shoulders are really bad. One is
Yeah, I know this is completely random, but kind of on topic. I've learned actually through some episodes that I've been doing that autistic children, when they start telling you they're hurting, they're really hurting
yeah.
because it takes them a
Yeah.
while to even recognize that they're in pain. And once they tell you they're in pain, they've probably been in pain for a long time. And so you
Is,
need to react pretty fast
is
to
it
it.
a delayed reaction or their threshold again is higher to
We
hit
believe
pain?
it's a higher threshold, not
Okay.
necessarily delayed. Yeah, it's interesting, and I don't know, like, anyone who's met me for 5 minutes is well aware I have ADHD and a pretty neurospicy brain. And I don't believe my particular situation is necessarily connected to neurodivergent, but it could
Could
be.
be.
But yes, we do see that oddly, particularly in severe autism,
Mhm,
where you're kind of a twofolds of hard to communicate, um, and hard to identify when they're in pain. Yeah.
mhm. Yeah.
So, sorry, I'm gonna circle back around. For you, Ashlyn, there is something, and I haven't tried it yet. I don't know that the hospital has gotten it yet, and it came out either this year
The
or late
brand new
last year.
stuff, I haven't tried it. I had a
Yeah.
doctor tell me about it just to say like, "Hey, this wouldn't have been this doc it's my primary has been with me for a long time." She's like, "Hey, just so you know, there's a new pain med that's
So it's
on
a
the market that's
yeah. So
not
it's
an
a
opioid."
new yeah, correct, non-opioid pain medication called I might butcher this, suzetrigine, I think.
I
The
think that's
name, like
right.
the brand name is like Jernavix. So I don't know why they put a V and an X next to each other. Um, and I
Just
haven't
a little bit
tried
different.
it, but it looks like there's a lot of promise in it. And it's for
Yeah.
acute pain.
Yeah,
Um,
we were thinking I need a hysterectomy, and that's actually where it came up because we were talking about that, and she was like, there's a new pain med on the market now, and it is one though I think it's important that you take continuously and not one at a time because the way that it works, it's more like
I
the
honestly,
gabapentin.
I have not. I've asked our anesthesia group if they plan on bringing it in, and they said to talk to the pharmacy. And then I
It's
reached out to one of the
expensive.
pharmacists, and I'd never heard back. But I think, uh, and I don't know if it's a pill or IV. Honestly, I have no idea how it's administered. But I
I
just thought of
understand.
that as we were talking about
Yeah, maybe
your
we'll
situation.
follow up with that. I don't know. I don't know which hospital system my hysterectomy is going to end up being. If it'll end up being Advent or HCA, I don't know where my OBGYN is. I think maybe Advent.
I think just for people out there, it's something to ask about if you have
Mhm.
a history of substance abuse. And I doubt it's at a lot of like private plastic surgery offices, but maybe something at a big hospital.
One of the other things that I want to make note of because people don't think about this. So, naltrexone is a part of Contrave, which is a weight loss medication. It's not one that's widely used because it doesn't work for a lot of people, but it is a mix of Wellbutrin and naltrexone. Naltrexone is traditionally used for alcohol addiction, but what we found is when we used it in a lower dose in Contrave, which is for specifically for weight loss, particularly for people who find a more addictive
Addiction.
uh, feeling surrounding food. So your bariatric, oftentimes, especially if you can't get a GLP-1 for whatever reason, your doctor may prescribe Contrave or just give you Wellbutrin and naltrexone because they're generics and they're really cheap. But you may not realize you need to make sure that your uh, plastic surgeon is aware you are on naltrexone because it cannot be used around surgery. Do you want to explain naltrexone and like the
Yeah.
medical?
So I mean, naltrexone essentially blocks the opioid receptors, and so really you can't be using it and trying to take opioids at the same time because your opioids essentially won't work.
Oh,
So,
yes, I should add
um,
it's also used for opiate addiction, but
yeah,
I see it more just in practice by chance. I see it more for alcohol use because we use it for both and food
I think
addiction.
it helps with addiction, right? As you said,
Correct.
alcohol addiction,
It covers
obesity.
it covers the opiate receptors. So if you take the opiates, it blocks it from making you high. And that's the idea behind
Correct.
its addiction use. But it's
Correct.
problematic when you have surgery
Correct.
because then it won't work.
Does it block? Yeah, I mean, it doesn't block just the high effect. It blocks the medication.
Correct.
So you don't get the high, but you also don't get the pain relief. So you can't be taking naltrexone if you're taking an opioid. It just won't work. So
Right. Same thing, dental. Like if you're someone who gets a lot of, that's why we always talk about when I know a client is about to go on Contrave, if they're choosing that as a weight loss medication, that you have to alert people that part of Contrave is naltrexone. And so, like for dental surgery, for if you break a foot, like we have to safely have you come off the medication.
hmm,
Well, and it sounds like to me, so basically, like, if you have a past with any of these types of drugs, one, let your surgeon know, like, as soon as possible. They need to be in the know of everything. They're already testing you for nicotine. You know what? Like, they shouldn't have to test you for everything else. Like, just be honest with them, tell them what's going on with your body, and then they can make a full plan of how are we going to come off of this. Because I know I even there's people in my family. Obviously, my ex has drug issues, and they don't want to take anything. They're like nothing. But there's sometimes where you need it, and like how you had that one patient where it's like, well, at least send it in, because I understand her thought process of like, well, if it's not there, don't have to worry about it. Won't even think about it. It's out of the brain,
hmm.
whatever. But it is nice to have just in case, because you don't know what you're going to feel, especially with the repair that happens, the lipo that happens. And you just want to, you don't have to suffer. Now, I get it that you're just very nervous to go back into that life, but just know if you have a support person there with you that knows what's going on with you, I think you'll be okay,
Yeah.
because between your surgeon, therapist, support person, like
And
it's
ideally, that person does not have a substance abuse history of themselves that
Oh
they are
geez,
trying
yeah,
to
that's a
work.
bad
So
combination.
that
please
is
don't.
sometimes where your support person, let's say if you and your partner are both in sobriety, then we may ask your mom to be the support person who holds the medication and disposes of the medication. I should also add that we also don't want to put your support person in a position where now they're holding medication that may be um, uh, tempting for
For them.
them. And so
Mhm.
again, we want to be fully aware and not put either you or your support person in a position, but it
I like
can be done
It
safely.
I like
can be.
I liked your idea, Ashton, of how, I mean, my answer when patients say don't even send it in is, well, let me send it in and then you choose if you want to pick it up. But I like your idea of we'll have a support person, because then you can pick it up and you can give it to someone trusted again, make sure they're not, they
Yes.
don't have a
And
history
then
as well.
have them have it and make a decision before you get on it of what the plan is.
Right.
So that way, again, if it sets you into something, the plan is already that person is going to fulfill the plan. We're all on the same page on why that is the plan. And then to me, the most important part is what is our disposal plan? When it is done, how are we getting rid of it? Where is it going? How are we not having
Telling your
it in the
friends,
A
don't get
lot
really
of yeah,
fancy. It's
I
normally where
don't
I
think
go.
I don't think we're supposed to tell patients this. We usually tell them to flush it down the toilet, or to, well, really what we tell them is to take it to a pharmacy, but a lot of pharmacies won't accept them
Yeah.
anymore.
We usually
Kind
recommend
of
they
return them.
dissolve it within a water bottle. This is how I know they do it
Mm,
in hospice. So you put all the meds in a water bottle, you shake it up, you put on that it is
down this.
poison, and you throw it out.
Mm. No,
You
why not
put what?
dump it down the sink or in the toilet?
I don't know why hospice didn't have us put it down the sink. They had us throw it away. Maybe so it
Well,
doesn't
it's
get
like
into the water source. I don't know.
yeah,
I
I was
didn't
Mm,
honestly at that point we were like in such a haze, but they were like
yeah.
before they left, they had to see us like dump everything into a water bottle, shake it up, dissolve it. Um,
There are places, like, I think if you Google, opioid disposal, like some cities will take them
Yes.
back,
I know we
fire
have a
departments, things like
local
that.
DEA office
Mhm,
that is known to the public, which not all of them are, and in front of it has a safe drop box, and you
mhm.
can put medication in the safe drop box. 'Cause I know like our local Walgreens won't take stuff, but there is
Correct.
like a usually it's like safe disposal. And again, it's also so that you don't have it in your bathroom and then someone again who's struggling with addiction, maybe you have a plumber or someone who you don't even know that comes into your
I mean,
bathroom
or
and
kids, right? Your
right,
adult kids or even younger kids get into your meds and take something that can be fatal for a young child, right?
right,
For a kid who's not an adult weight.
yeah.
right. Because
God, that
again that
was
those medications can be weight based, yep, and especially even when we were in hospice, like part of the reason why I think they like check is like there have been cases where the kid was that in here, I don't think we talked about it on here, someone else I was talking to where they had a situation where they told the kid to go in and get the Is that here where they told him to go get the Tylenol out of the? Okay, so there's it was a baby and it was liquid Tylenol, and they said, "Well, go into the cabinet and get the liquid Tylenol." They took out something that they thought was liquid, and it was morphine. For a hospice
Oh.
patient who was in the house as well. And so, if they hadn't reversed that with Narcan, which is also very important, if you're picking up narcotics, you should be picking up Narcan, um, so that you can reverse it. So, you don't
That's
regularly give out Narcan as a part of your narcotic.
I think we do. It's prescribed. I don't know that everyone necessarily picks it up.
Okay, because you can, yeah, you can pick it up without a prescription. So I always remind people of that you can go get it. At our health department, our local health departments, I carry it just as a social worker. I have it in my office, in my car, and in my purse. Because it's a life-saving medication.
And
it is.
Narcan is
What is something like
also
that
known as
cost?
naloxone, and it's an opioid reverser. I don't know if you said that. I might have
Yes,
blanked for
sorry,
3
we
seconds.
should
Yeah.
explain what that is. So if someone is overdosing, you can reverse it.
Mhm.
It has 2 pens. Also, very, very important if you are taking the B12 nasal spray as a bariatric patient, that is the same device that generic Narcan comes in. So super important that you are not displaying them in the same place, so someone
I'll
isn't
mix them.
taking your B12. When I picked that up and saw that, I was like, I got on Instagram immediately. It was like, freaking PSA. This is the
Yeah.
same, and I literally showed
Wait,
it. I'm like,
they're in the
this is
same, like, place in the pharmacy, you mean? Or
no, they are in the same. The delivery device is the
yeah?
same.
It's a nasal spray, okay.
Correct, but the actual there's the name brand Narcan has a different injector, like the actual delivery device, the plastic thing that it's in that they put up the nose looks different. But the generic B12 nasal spray that it is the same company that makes the same plastic. So if
Oh,
you think when you're picking that up to the average person, because most people have never seen a B12 nasal spray, they would
I've
think that's Narcan.
Yeah.
oh,
It
I
looks
would
like
say I've never
Narcan.
seen
The
B12.
packaging looks like Narcan. The
I
box
see.
it comes in
I've
looks
never seen it, so yeah,
yeah.
yeah. I've never
Um,
seen either, so I have no idea
I was gonna
what
say I
either
can actually
medication looks
show
like.
it, but I won't go get both of them. But when I went to pick it up, I was like, oh my god, it's because the manufacturer of the actual delivery device is the same.
It's the same,
Yeah.
interesting.
So again, very important, bariatric patients, because that's a lot of who we're talking to. If you're on that B12 nasal spray and you have Narcan because you're on a narcotic, put it in very known different places. So that way someone going to get it is not grabbing your B12 because that will not help reverse an opiate overdose, obviously. It
Can't
can
get
be
to your
very
opioid
scary.
bottle.
It'll be very obvious once you start that process.
Okay, yeah, yeah. Also, B12 nasal spray. I don't know why, but all B12 is like dyed red.
Yeah.
Narcan does not have color. So
Oh,
Smart.
interesting.
yeah,
There you
B12
go.
I don't know why they put it in the nasal spray because if you blow your nose or any of it, like looks like you. I'm like, who did this?
Red like Mel's shirt shade or
No,
It's like a red.
it's more of a
mm,
like a red, more red than tea. But on that,
okay,
I'm trying to. I don't really have anything the
that was
correct
that.
color.
Because even the dissolvables are red.
Yeah, like more
Yeah.
like that.
Hmm.
Mm-hmm.
Which I'm like, it's nasal spray that you make. Make it clear. Like I
Make
understand for like the vial, like the IV, so you can see it to put some
Yeah.
Right.
coloration in it, but maybe whatever it's made out of, I don't know, like crushed up bugs or whatever. It's like it's red. I don't know, but it's
Maybe
like
B12 is just red. I think it might be.
it has to be because why would they make the nasal spray red?
That's
It's
wild.
going in your nose.
I
Yeah,
think it's
I know.
always red because it's got a metal in it.
Oh, is
Probably
it?
some sort of root that's in it that makes
All
it a
right.
color.
Now we got to Google this.
It's
Why
not a root. It
is
is
B12 always red? Cobalt in its chemical structure.
yeah,
Cobalt
cobalt.
is red. Now we know. Okay, they can't help it.
The cobalt is red.
Yeah, cobalt. I mean,
I think
How
it's
fun is
blue in
that?
sometimes, but isn't blue kind of the opposite of red in the like color wheel?
Yeah. Yes. That's why I was wondering because the cobalt actual fucking brand for tools is blue. So, but I think that's kind of interesting considering
That's okay.
it's
As a random fact of the night, I think B12 has to be red for a reason.
yes,
They're
it
not
does.
dyeing it red, so it looks like you have a bloody nose when you're taking
Yeah.
your B12.
So is there anything else that we should cover about pain management that you guys think that we may have missed on this episode before we wrap?
So I would say for me the biggest thing is, and I think we might have mentioned this already. Ashton may have said this, but if you have a history of substance abuse, be upfront with your surgeon. I think it goes a long way to tell someone that than for us to find out after the fact, or again have someone spend 3 days in the hospital and then they're questioning what did we do something wrong? Was there a complication that we're not aware of? I mean, I'd definitely rather know upfront and have a plan than find out after the fact. And then also it kind of raises red flags when you find these things out afterwards. Like, why wasn't this person upfront with me?
Well, and I know it's because they're nervous to tell you. They don't want you to judge them. That's a shame, embarrassment, judgment where it's coming from. But no, guys, like these are doctors. They're probably fucking hella proud of you that you mentioned it and that you're sitting in their office clean. So, don't feel
I'd,
ashamed of your past
I'd
because,
say if they
like,
shame you, go somewhere else.
yeah,
Yeah, that's
if they
actually
do
got to be
shame
part
you,
of
don't
mine.
go
Yeah.
to them.
If they
Yeah.
give you a hard time, then that may be
Yeah.
a thing. I would also say if pain is what's preventing you from getting skin removal, have an honest conversation with your doctor about what the plan is. Because if you're afraid of pain and you don't want to take pain medication, you may not be aware of all the other things like Esperol. Like, we're actually going to treat you with muscle relaxers and nerve pain,
Yeah.
and maybe we're going to do a nerve block. Like, we have
Right.
a bunch of other tools in our toolkit, and it isn't like your surgeon isn't just like, ooh, how can I create the most pain? Like, most surgeons are actually I've found are more concerned about my pain than I am. So,
Yeah.
because they also don't want, again, you to be rehospitalized or you to tell
Mhm.
all your friends, don't have, don't have it. It was terrible. They also want you to have a positive experience. I mean, at the end of the day, part of it is a business. They want you to come back, tell your friends how it was great.
Yeah, I
Um,
mean, I said two bad stories. I'm going to say one good one. So I had a lady who was in her 40s. I think she's had 5 kids, 4 kids. I can't remember. Multiple kids.
poor body.
She put off her plastic surgery for years, and so I saw this lady maybe 4 years ago for the first time. Then she disappeared. Then she came a year later for another consult. Then she disappeared. Then she came another year. Did her first surgery finally. We did it. I think it was maybe like 7 or 8 months ago. I think she was, as you said, Ashton, just fearful of like the recovery, the pain. She came into like her first or second post-op visit, and she was like, "When can I schedule my second stage?"
Ah,
That is
nice.
unbelievable. You had a
Yeah,
C-section, you dealt with major abdominal
yeah. You had a
surgery,
child,
and you
four
had
children, five
a
children.
baby? Like,
Yeah,
you had to because sometimes it'll be like, "Oh my god, that was so awful, it's so painful." I was like, that might have also been because you just had a baby and you
yeah.
weren't sleeping and your focus couldn't be on your recovery. It was like keeping a little baby alive. So maybe if we focus on your recovery and taking care of you,
Might
the
feel better.
outcome may be different.
Yeah.
Yes. And I would agree. I think that when you actually have recovery that's just for you, it's going to go completely different. Like, and you shouldn't have to take care of anything, right? Like, this is your time to heal. This is your time to process everything. Like, don't be trying to work. Don't be trying to pick up the kids from school. Like, just chill the fuck
Yeah.
out.
And I
Yeah.
would say too, like, advocate. So one of the things I did, and this isn't always possible, but I always try to actually get anesthesia on the phone the day before. This
Okay.
isn't always possible because of how the flow works, but at least with the group that I've used for my last round, it's the same guy. So sometimes it's the partner, but it's these two same guys. And I had really advocated, can I talk to him the day before? Because I have a lot of issues. I want him to be aware of it. And I remember he kind of chuckled on the phone because he was like, so you wanted to talk to me the day before? And I'm like, yes, I just want to I want to present you with some information.
Here's
So
my
in case
report.
yeah,
Let me
no,
send it to you.
literally.
What's
I
your email?
literally I left it at the office to give to him, and I said, if you wanted to research it or understand like what's happening, if you wanted to look at these pathways, like I wanted to give you time because I had previous anesthesiologists that are like, I'm sure we're like Google it, like what is this? I've never seen this, and now I'm supposed to be operating on this person in like 30 minutes, and I don't know what's going on here. He was pretty cool because we were able to have a pretty good conversation. I was able to give him, if you've had positive surgery, one of the things I've really found helpful is to get the anesthesiologist report. So that first Mayo Clinic doctor who like got it and made the plan, I got his, which was kind of hard. I got his actual like surgical record And I gave it to the next one. And I said, this surgery went well. Can you follow his plan? Can
Yeah,
you
that's
do
always
what
a good
he
idea.
did?
Mhm.
And if you had a bad one, like I
Same.
did, I'm like, can you look at what they did
Don't
and
do that.
not do that? And I remember the one guy like looked it up and he was like, oh, knowing what we know now, that was a bad plan. I was like, yeah, but we didn't know. It wasn't their fault. But he had no idea. He was going by, I'm a large person at the time. So I got a bunch of medication, you know, like they kind of
Yeah.
threw everything at me in hopes that I would not have pain when I woke up. And I can appreciate that on some level. But I was able to say, look this one up, don't do that, look this one up if we can. And they may say, for this kind of surgery, we can't do that. So I know I had a pain block once for a skull surgery. And I was like, that was so awesome. I woke up and felt great. And I was talking to the next guy and he was like, we can't do that for this kind. I was like, why not? He's like, because it's your entire, like, I can't
Yes,
block that much.
area,
He's like,
different
that's
height.
really good for your head, but I can't do it for this. I was like, okay. So we picked up a different idea, but just advocate. And yes, it may seem silly and it may not be possible. They may say, hey, it's just the anesthesiologist who's on that day and you can't talk to them or whatever. They're not in the office or whatever.
Right. Yeah, they're
Um,
not relatively available
right.
for you.
But for this one, it was, and that was very reassuring because I could like explain all this information to him. And then he had a little more time to look it up and then he remembered me. He's like,
Look,
I remembered you.
you are not forgettable by
Which-
any means.
Which was really helpful because for the next two surgeries, he's like, oh, we're just doing what we did last time. I'm like, yes. He's like, okay.
Perfect. Perfect. All righty. Well, thank you so much, you two, for going over all of the types of pain and what we can do to help ourselves support what we can do about like being like open and honest and being upfront with everyone, having a plan. I think that's perfect. Just have a pain management plan. What you're going to do, who you're going to do it with, talk to your doctors, just be more informed. So I want to thank everybody so much for tuning in. If you have any questions, of course, don't hesitate to message any of us. All of our contact info will be in the description. And go ahead and ask whatever questions, because you never know, you might hear us later on answering those questions through the episodes and getting more involved with you guys. So thank you so much. And until next time, stay safe and talk to your doctor and be honest. There we go.
Yay!
Bye.